Okay, I got it. Go ahead.
All right. Thank you again, everybody, for joining today. And thank you for the great introduction, Dr. Sekar and Dr. Saha. Thank you, the staff of BMMSH. And so what I'm going to be talking about is the role of the clinical pharmacologist, pharmacist in stroke management. And you heard in that nice introduction that I've been practicing in the neurology stroke world for over 30 years now. And so my practice, just a little bit of background, is primarily with stroke patients, ischemic stroke or hemorrhagic stroke, and I'll share more information about what the differences are. Neurocritical care patients, we have a specialized neurointensive care unit, and then also general ward patients with other, like infectious diseases of the brain or tumors, Parkinson's disease, other neuroimmunologic diseases. Okay, so objectives for this presentation is I'm going to just first of all talk to you a little bit about what is a stroke, and we've all heard of that term, and then I'm going to briefly tell you a little bit more about the different types of stroke, and go over some of the guideline recommendations for common medical therapies that we use for acute ischemic stroke. And I will be talking about the role of the thrombolytic medicine, alteplase or TPA for acute ischemic stroke. And then the last thing I want you to know in terms of when I think of the treatment of acute ischemic stroke versus the acute intracerebral hemorrhage or the bleeding kinds of stroke, probably the most significant difference in the acute setting is the management of the blood pressure. So I'll go over that, and hopefully you can know the difference there. So again, what is a stroke? This is a very simplified picture, and it's a sudden lack of blood flow or bleeding due to a rupture of a blood vessel. So an ischemic stroke, you can see here, is due to a clot, and that's about 85 to 90% of all strokes are ischemic strokes. And the rest, therefore, about 12 to 15% are the hemorrhagic or bleeding types of stroke. Now, ischemic strokes there's multiple causes, and I'll kind of go over some of this some more. I think before we learn about some of the medications and treatments, we have to really understand these definitions, the epidemiology a little bit, the pathophysiology, before we can kind of understand how we can, treat this and optimize outcomes. So just some numbers. In the US, we always quote these numbers, about 800,000 cases. These are both acute first time and then subsequent strokes. I got a number for India. It says here, this is 1.5 million cases of just first time stroke. So the actual total number of strokes in India is probably much, much larger than that. And you would expect that, based on the population. In the US, it's a fifth leading cause of death. And it's also a leading cause of long-term adult disability, which is the case in many developed and industrialized countries. And many, countries like India are catching up to these developed countries as well. And there's causing a lot of disability in adults. So again, talking just a little bit about some of the subtypes of stroke here. You can see about 85 to 90% are ischemic. The rest, 10 to 15%, there's different types of bleeding types of stroke, the intracerebral hemorrhage or subarachnoid hemorrhage. And on this picture, this is from the most recent guidelines that are been put out by the American Heart and American Stroke Association. So if you take the ischemic strokes, it says there 77% are non-lacunar. Lacunar means those are the blood vessels that are deep in the brain. So the lacunar strokes there are 23%, and the non-lacunar are the 77%. And if you split that further, you can see for non-lacunar strokes, 35% means cardioembolic. So that means cardio, remember, is heart. We all know that. And embolus is a clot. So a cardioembolic would be a clot that arises in the heart that travels up the brain to cause the stroke. Cryptogenic is an unknown cause. We don't know what the cause is. Large artery would be one of the big blood vessels in the brain, and then other causes of stroke would be things like trauma causing a clot, or maybe clots from use of illicit substances or drugs. And then under cryptogenic stroke, there's ESUS, E-S-U-S here is another, that's a sort of abbreviation for embolic stroke of unknown source, and then non-ESUS. So when we think of acute ischemic stroke, looking at the pathophysiology a little bit, you can see in this picture, there's that core. So that's the area of the brain that's actually the dead area, the damaged area that you're not going to recover. So that's due to that clot that blocked off that blood supply to that part of the brain. So you have this core. But what we're trying to do is we're trying to salvage that area called the penumbra. And that penumbra is an area where there's decreased perfusion, decreased blood flow, and so that can affect the size of stroke you can get. So we're trying to salvage as much of that area, that penumbra, so that that stroke doesn't get larger, because strokes can be of various sizes and they can expand. So in the acute setting with acute AIS is acute ischemic stroke, the core we're not going to be able to change, but it's that penumbra area that we're trying to salvage to improve function. And you can see here, it says the average patient loses 32,000 neurons every second. So what are some of the sources of these blood clots to the brain for ischemic stroke, acute ischemic stroke? This is just a graphic that I use when I teach about this. And you can have, intracranial means in the brain, the skull, the intracranial blood vessels. You can have atherosclerosis there. That causes that blood clot to form. In your carotid, you can have similarly a plaque or atherosclerosis, and pieces of that, the clots can break off and go up to the brain to cause a stroke. The aortic arch, there's plaque, and again, pieces of that can travel up the different blood vessels to cause a stroke. And then if it's a cardioembolic source, that may be due to various reasons. For example, if you have a type of a heart arrhythmia, probably the most common one we talk about is atrial fibrillation, where you have irregular blood flow in the heart and now clots form, and then those clots can again travel up to the brain to cause the ischemic stroke. If you have valvular disease, if you've had, for example, a mechanical heart valve, or some other type of heart valve, mechanical heart valves especially are known to be very likely to cause thrombosis or clots. And then sometimes you will see actual clot sitting in the heart, that in this picture, that ventricular thrombi. And we call it a left ventricular. Most commonly, it's in the left ventricle. You should never have a blood clot in your heart. That should never happen, because as we all know, your heart is like a pump, very efficient pump, and there should never be a clot sitting there. So if there is, if you see that on the testing, then you definitely suspect that it's a cardioembolic source. That could be the source. So what are some of the symptoms again? This is lists some of the symptoms here. Most important word to remember is that these symptoms are sudden onset. They don't happen gradually or over, days or weeks. It's very sudden onset because a clot blocking off a blood vessel is a sudden event. And so this is sudden weakness, numbness, paralysis, face, arm, leg, on one side of the body, loss of language or slurred speech or understanding of language, sudden loss of vision, sudden onset, worst headache of life. So a very, very severe headache that if somebody comes in with that presentation, we think of some type of a hemorrhagic, one of the bleeding types of stroke is what the first thing we think of. So those are the ones that cause a very, very severe sudden headache. And then other symptoms like unexplained dizziness, loss of balance, or coordination. So why is it important to know when the patient was normal? Now I'll come to a couple more slides, but one of the treatments that we have for acute ischemic stroke, and actually in the US, the only US FDA approved medication for acute ischemic stroke is TPA or Alteplase. So that's a thrombolytic, and I'm going to talk a little bit more about that, but I wanted to show you this. Here, x-axis is the number of people you need to treat with IV, with that IV TPA for one person to get back to normal, in minutes, so in how quickly you're able to treat them. And the y-axis is the odds ratio of a good outcome. The higher that odds ratio, the better the chance of a good outcome. And you can see if you can treat somebody in about 60 minutes, 1 hour from the last time they were normal, 1 out of 5 of those people who you'll get back to normal like they were before. Whereas if you go out past 3 hours, you're now approaching, a 1 out of 8, 1 out of 16 people, you'll get back to normal. So very, very, very important if you are going to use this medication that you're able to start it as soon as you've confirmed that diagnosis. Other treatments that have, I would say in the last 5 years now, probably the single most important medical advance we have for stroke treatment is mechanical thrombectomy. So what this is kind of a picture that this is the interventionalist it's very similar to doing like a heart cath, a cardiac catheterization, but this is where they put the catheter up to the brain. And you can see it goes into the clot or right before the clot, and they can try and suction the clot out, or in the bottom there, sometimes they may try and put a stent to keep that blood vessel open. So this is another treatment. We call this endovascular therapy or mechanical thrombectomy. And in the last 5 years, like I said, this has been shown to also very, very significantly improve outcomes if you're able to do this kind of a procedure. And this is just a picture of one of the interventionists that I work with. You can see here on the left-hand side where this arrow is, you can see the blood going in the blood vessel, and then on where that arrow is, it just stops. So they went in, they put the catheter, and in the middle you can see the clots that they were removed from that blood vessel. And on the right-hand side is the picture after they removed the clots, and you can see the blood vessel now. There's the perfusion has been established, where previously it just stopped where the arrow was, and now it's reperfusing that part of the brain after they remove these clots. So what are some risk factors for stroke? These are things that are very, very important, and I'll kind of come back to some of these toward the end of the presentation. But things we should all probably be familiar with: having a heart arrhythmia, most specifically atrial fibrillation, hypertension, high blood pressure, cardiac disease, diabetes, cigarette smoking, alcohol abuse, and then hyperlipidemia. These are not all of the risk factors, and we call several of these, we call them the vascular risk factor, which means if you're diabetic, for example, and you have hyperlipidemia, and you're a smoker, you're pretty high risk of developing not only strokes, but also heart attacks and heart disease as well, clearly. Okay, so principles of acute ischemic stroke care. We want to achieve timely recanalization, reestablish that blood flow in that occluded artery or that blood vessel, and reperfuse the ischemic tissue. We're trying to save that penumbra. So the methods to do this, if you have access to alteplase or TPA, and then that mechanical thrombectomy that I showed you, that's that interventional procedure to try and remove the clot. Other things you can do medically is optimize blood flow. You want to make sure that you don't suddenly drop the patient's blood pressure very low, because if you drop the blood pressure very low, you reduce the amount of blood going to the brain. And so that can actually worsen that penumbra and make that stroke larger. So you have to be relatively careful with the blood pressure that you don't drop it. So you may need to give them IV hydration or IV fluids, and then avoiding secondary brain injury. And so, like I mentioned, alteplase is a thrombolytic agent that's approved in the US, for example. Only, it's actually approved to be given within 3 hours, but there have been studies that have shown that it can be administered up to 4.5 hours after the person was last seen normal. So what's very, very important with stroke patients, with ischemic stroke patients, is to try to understand when were they last normal. Was it 10 minutes ago, 2 hours ago, 6 hours ago? So that's very important to try and get that history from. And what is difficult in a lot of these patients is many of them may not be able to tell you, well, I was normal at, 7 o'clock, now it's 9 o'clock. They're just not going to be able to tell you. So if there's family available, any bystanders who may have seen them, or anybody, the most important piece of information we need to know is when were they last normal. And then again, IV alteplase, you can only administer it within 4.5 hours of the last time normal. Now, why is that? What happens if you give IV alteplase, let's say at 8 hours after the last normal, or 24 hours? What happens, the risk is that once the stroke has been established, the neurons get damaged, the blood vessels get damaged, and therefore if you reestablish that perfusion at a much later point in time, you can your risk of bleeding in the brain, which can have a very high mortality, is very, very high. So that's why there's this very, very short time window to get this product administered if available. Whereas these endovascular treatment, that mechanical thrombectomy that I talked about with a catheter, that treatment can go out as far as 24 hours for patients if they have one of the large blood vessels occluded. So again, briefly a review of alteplase. It promotes thrombolysis by hydrolyzing the arginine-valine peptide bond in plasminogen to form the active plasmin. And then plasmin works on that fibrin-bound clot to try to dissolve it. Now, there are some older thrombolytics, at least in the Western countries, we don't really use anymore streptokinase and urokinase because they were much less specific, less fibrin specific than alteplase, and so the risk of bleeding was higher with them. So alteplase is really sort of right now our main agent that we use. So a couple of things about this: it's a thrombolytic. And therefore, you have to be fairly certain of this diagnosis. You have to administer it within the 4.5-hour window. And there are some contraindications. And for example, if somebody had a severe head injury a month ago, if you give them a thrombolytic, you can cause severe bleeding in the brain. So that can be, again, like I said, have a very high mortality. So you don't want to do that. Previous stroke within 3 months, previous primary intracranial hemorrhage or primary brain hemorrhage, suspected, if you suspect any kind of brain hemorrhage, you will definitely never give this product. And if they have a recent, for example, GI, they have cancer in their gastrointestinal tract or GI bleeding within 21 days, it's also contraindicated due to the very high risk of bleeding. So this is just, I've listed the dose for this product, and it's given as 10% is a bolus, and then the rest of it is given as a 60-minute infusion. So for our institution and our guidelines from the American Stroke Association, when the patient comes to our door, so if they come, for example, the emergency department, to the time they get started on this treatment, our goal is 60 minutes or less. Again, the quicker you can administer it, like I showed you, the much higher likelihood you're going to have of a good outcome. This is just a picture of it comes in 50 and 100 milligram vials. Most commonly for a stroke patient, you're probably going to use, the dose again is based on the weight, and I've done a calculation there in an 80 kilogram adult, what the dose would be. Again, the total dose would be 72 milligrams. So you would give 7 milligrams, about 10% as a bolus, and then the rest, 65 milligrams, you would give as a 60-minute infusion. After you give this agent, you have to monitor the neurologic exam, the blood pressure, and for any signs and symptoms of bleeding. And it's fairly extensive. You have to monitor the patient for up to 24 hours. And after you give it, your goal blood pressure is to keep it below 180 over 105 for 24 hours after you administer alteplase. So therefore, you may need to use blood pressure medicines. And I've listed some of the common ones that we use. Labetalol, nicardipine is a calcium channel blocker. Labetalol is a beta blocker to control blood pressure. There are some others you can use, but these are a couple of the most common ones that are utilized. After you give this, the most sort of significant risk is intracranial bleeding. And it's not very common though. Like I put the number there, is maybe in the range of about 6%. And then there's a small risk of angioedema, that's swelling of the throat and the face. But again, the risk of that is pretty small, maybe 1% or less. So I'm going to now switch gears and talk a little bit about just some of the complications after stroke. I'm not going to go cover all of these here, but I'm going to cover some of them. And so some of the neurologic complications are, again, bleeding or hemorrhage, brain edema, recurrent stroke, seizure. Some of the medical complications are pneumonia, urinary tract infections, UTI, DVT or PE, deep venous thrombosis or pulmonary embolus, and then arrhythmia. So just talking a little bit about the medical complications, studies have shown that stroke patients, about 30 to as high as maybe 50% of the time after an acute ischemic stroke, they're unable to swallow safely. So if you're giving them, letting them eat a normal diet, or you're giving them even medications orally, and their muscles that control their swallowing and their throat are affected, you may cause food or medication to go into their lungs, so they can put them at a very high risk of pneumonia. So we automatically screen all our patients prior to giving them any type of a diet, anything to eat, or any medications. And if they're not able to swallow safely, then we will usually put a small tube of like a feeding tube in their nose, so we can give them nutrition and medications that way. So some of the complications, again, hemorrhage or bleeding, there's a higher risk with the larger the size of the stroke, and a little bit higher risk if you've used a treatment like alteplase. So for this, you have to just monitor them clinically as carefully as you can. Strict blood pressure control, less than 180 over 105. and then avoid increasing their risk of bleeding. So here you have to be careful that you don't automatically put them on prophylactic or therapeutic antiplatelet type medicines like ASA, acetylsalicylic acid, aspirin, heparin. Any antiplatelet or anticoagulant type medications for at least 24 hours after they've gotten alteplase are not recommended. This is a picture of what that swelling in the brain looks like. This is a CT scan, and you can see the dark area of the dead brain, the stroke, and then in A, and then in B, the difference is here. What has happened in this patient? If you kind of look on the right-hand side, if you can see my cursor here, the part of the brain has been, not the brain, sorry, part of the skull has been removed here. So we call that a hemicraniectomy. So the neurosurgeon went in and took out a piece of the skull. So the reason for that was that because the brain is basically a closed space in your skull, and if you have a lot of edema or swelling, you can compress a lot of vital parts of your brain, and it can be very devastating. So here, when you remove a piece of the skull, then that gives the brain room to expand out that way. So some other complications, I mentioned deep venous thrombosis or pulmonary embolus. So pulmonary embolus accounts for about 10% of deaths after stroke. Many of these patients, as you would expect, may be paralyzed on one side. They may be very immobile. They may be laying in bed for a long time. So you can prevent this. So common methods to prevent this are unfractionated subcutaneous heparin or low molecular weight heparin, for example, enoxaparin. There are several others that are available. Compression boots, those are boots, those are like, people call them compression stockings that apply pressure to the lower extremities. And then early mobilization is key, making sure the person is able to, at least maybe sit in bed, or if possible, walk or ambulate, because that reduces your risk of developing these complications significantly. So now these are the American Heart Association, American Stroke Association guidelines. This is a many-page document. I'm not going to go through everything on this, and I'm just going to go over some of the. I do encourage everybody to look at this, there were 10 take-home messages here, and I'll go over 7 of those. And you can see I've listed them here. So the first one is you want prevention strategy. So that depends on the type of stroke that the person had. So you've got to try to understand what is the cause of the stroke if you can. Management of those risk factors I talked about, vascular risk factors, very, very important for preventing further strokes. Again, control of diabetes, smoking cessation, management of hyperlipidemia, hypertension. Intensive medical management is often performed best by a multidisciplinary team. So that may include doctors, pharmacists, nursing staff, really multidisciplinary teams, very, very important to achieve those goals. Lifestyle factors, including healthy diet, physical activity, are important in preventing secondary strokes. And then low salt and Mediterranean diets are recommended for stroke risk reduction. Number 4 here was changing patient behaviors, like trying to make them improve their diet or exercise more, or be more compliant with taking their medication. It requires more than just their doctor telling them or giving them some information. It's really, all of us need to be involved in this. Only then can we be successful. Antithrombotic therapy. So this includes antiplatelets or anticoagulants. So antithrombotic, specifically antiplatelet therapy, is recommended for nearly all patients without contraindications. And we typically, in ischemic stroke patients, do not use combination of antiplatelet and anticoagulant medications. Occasionally, we will use more than one antiplatelet. We call that dual antiplatelet therapy, 2 of them. But that's only recommended in very specific situations for a shorter period of time. Atrial fibrillation, again, is a type of arrhythmia I talked about. Remains a common high-risk condition, and anticoagulation is recommended if you do find this. And you can only again find this by EKG monitoring or by doing more of a continuous, longer-term heart rhythm monitoring. And in patients with that embolic stroke of unknown source, we don't really know why they had it, should not empirically be treated with anticoagulants, or ticagrelor is another antiplatelet medication because it was found to be of no benefit. So after an acute ischemic stroke, if they've gotten TPA, I had mentioned what to do in terms of watching their blood pressure and blood pressure control. But let's say they did not get alteplase, they were not within that short time window, and they're very hypertensive. So you may need to give them blood pressure medicines, antihypertensive medicines, but usually we'll let their blood pressure go fairly high. You can see here diastolic over 120 or systolic over 220, then we are more likely to want to treat. I mentioned earlier that if you drop the blood pressure too low in the acute setting, you can make that penumbra worse so that you can extend the size of the stroke. So be careful when you do treat the blood pressure. Again, you want to try to use medications that have minimal vasodilatory effects, like labetalol. Those are probably one of the most common that we use, and the nicardipine is a calcium channel blocker. Clomidopine is another calcium channel blocker. Antiplatelet therapy from guidelines, oral aspirin is recommended, usually start at 24 to 48 hours. Clopidogrel is another antiplatelet that is an alternative to aspirin. And then if they've gotten IV alteplase, like I said, it's not recommended to give them any antiplatelet within 24 hours of that. So now switching gears, I was talking about acute ischemic stroke. So now I'm going to talk a little bit about a primary brain hemorrhage. So remember I said ischemic stroke is about 85 to 90% of all strokes. So 10 to 15% of all strokes are primary brain hemorrhages. So that's what I'm talking about here. So let's say the person is on warfarin and now they had a brain hemorrhage. So you need to correct that deficiency they have of factors. So that may involve reversing the effects of the warfarin. If they have very thrombocytopenia, is very low platelet count, they may need to receive appropriate blood products. Blood pressure recommendations after intracranial hemorrhage. So again, the difference here you can see, and I highlighted it, for a primary brain hemorrhage in the acute setting, we definitely want to lower it, because we know that if the blood pressure is too high after a brain hemorrhage, you're at risk of recurrent bleeding, so that you can have even more bleeding. And the more bleeding you have, the higher the chance it's going to cause more problems, and even the mortality goes much, much higher. So here you can see after a primary brain hemorrhage, acute lowering of the blood pressure to 140 or less in the acute setting is recommended. And again, these are just some of the medications that are listed in the guidelines, comments, or IV push doses, or IVP is intravenous push, CIV is continuous intravenous, and kind of common doses or dose ranges for these medications. Now, you may have some of these available in India, you may have some different ones, but again, I think the thing to remember is you want to avoid medication that may dramatically drop the blood pressure a lot. So probably the first line really across the board that we use is labetalol, is kind of our first line medication. Seizures and anti-seizure drugs. If a patient has a brain hemorrhage, they have a higher risk of developing seizures. So those need to be treated. Phenytoin, levetiracetam, there are some other choices, but those are some of the medications that can be utilized. Patients who have a change in their mental status, and if you're able to do EEG monitoring and you see seizures, you definitely need to treat them. And so again, I listed just sort of common adult doses for these two medications. There are other choices as well. These are probably the two most commonly used medications for seizures or seizure prevention. If they've had a brain hemorrhage, they're obviously at risk of having a recurrent, more intracranial hemorrhage. So the most important thing to remember here is long-term blood pressure control. That's the most important thing. Long-term goal of systolic less than 130 and diastolic less than 80 is reasonable. Lifestyle modifications, avoidance of alcohol, more than 2 drinks per day. Smoking should be avoided, illicit drug use, and if they have sleep apnea, the treatment of that is also beneficial. I'm going to talk a little bit more about some of these medications here. I'm not going to cover all of these, but these are at least in North America, the most common antiplatelet medications that we use, and by far the most common is aspirin. I would say followed by clopidogrel. Dipridamol, not really that common anymore, and then ticagrelor is another option. I'm going to talk primarily about the first two here. So again, the mechanism of action of aspirin is inhibition of platelet generation by thromboxane A2. It's irreversible platelet inhibition, and 2 to 4 days are required for 20% of platelets to turn over to reverse the effect. And it reduces the relative risk of vascular events by about 20 to 30%. Clopidogrel is a thienopyridine. It's a prodrug activated by CYP2C19. I've listed sort of common loading doses and maintenance doses. And here half-life is listed. There's a black box warning, decreased effect in patients with 2 loss of function alleles of the CYP2C19 gene. So that's more common in certain Asian populations. We in North America don't routinely do genetic testing when we use this, but it may be warranted, in certain populations if it's available. Cautions with it are neutropenia and then bleeding, minor or major. Anticoagulants, there are several available. Warfarin is sort of your traditional gold standard that's used. I'll just kind of skip through here. So it's things to sort of some clinical pearls about it. What are some of the risk factors for bleeding if you have a high intensity of anticoagulation? If that PT or the international normalized ratio INR is high, greater than 4. In elderly, high risk of bleeding, longer the duration of treatment. If the person has highly variable INRs that they're going up and down a lot, history of GI, gastrointestinal bleeding, hypertension, anemia, malignancy, trauma, certain types of stroke, serious heart disease, renal insufficiency, and other drugs that can interact and increase the risk of bleeding. So in North America, we have other options. Now I would say that fewer and fewer patients anymore are being put on warfarin. We are using some of these alternative agents, which are not as commonly utilized in India, but you may see, for example, dabigatran occasionally used, and which is a direct thrombin inhibitor, rivaroxaban and apixaban are what we call them DOACs, direct oral anticoagulants. And there are many benefits of these other agents. They're fixed doses. They don't require the careful monitoring that warfarin requires. but as you may be familiar, they're also a lot more expensive than warfarin, so that many people cannot afford these medications. In atrial fibrillation, so I'll talk a little bit about this. This is the heart arrhythmia, and the treatment recommended for this is anticoagulation. And these are two scores that are used, sort of a risk assessment. The CHAD score is the original score. If somebody has, for example, CHF is congestive heart failure, you give them a point, hypertension, age, diabetes, stroke, or TIA. So you add up their points, and CHADS 2 VASC was sort of an improved, updated score. And if you look here, so if you have a CHADS 2 score, the highest you can get here is 9. So your risk of stroke per year is very, very high, 15% per year, and it's a cumulative risk. So it's 15% per year and going up, whereas if your CHADS 2 score is 0, it's a 0% risk. So generally it's recommended if you have a CHADS 2 VAS score of 2 or higher, you should be treated with anticoagulation with like warfarin. A little bit more about warfarin. Bleeding risk, 1.3% versus 1% for controls. It reduces the risk of stroke, absolute risk, if you're not on anticoagulation, from 4.5%. Again, it depends on your CHADS 2 score, to 1.4%. There is a small risk of this skin necrosis, especially in patients with protein C or S deficiency. It's got a narrow therapeutic range. And I think an area where definitely pharmacists can significantly impact the safety and the efficacy of use of warfarin is if you can be involved in some sort of like an anticoagulation clinic to be able to monitor the INR and improve the TTR is time in therapeutic range. So if you're able to be involved in a setting like that, that has been shown to be significantly improve the safety of using this medication. And the common international normalized ratio INR that is used for warfarin is a goal of 2 to 3. And this is some data from some of the original studies with warfarin. And you can see the INR, and sort of that dotted line is a ischemic stroke rate goes down. And then the intracranial bleeding rate goes up the higher the INR. So that's where the goal of 2 to 3 came from, is to balance that, the safety and efficacy. So I mentioned these, kind of skip through this. Some other recommendations: hyperlipidemia, cholesterol lowering therapy. In our most recent guidelines, a high intensity statin, for example, atorvastatin, is indicated. There are obviously other statin medications that you could utilize. If they're still having high lipid numbers and they're on a statin, you can add ezetimibe. And now we have some newer agents available in North America, very new PCSK9 inhibitors. I'm not aware if they're available in India yet, but that's another option if they continue to have high, very, very high numbers refractory to the statin and the ezetimibe. So I'm just going to review some common medications in acute stroke, alteplase, availability or administration within 4.5 hours, 4.5 hours. Aspirin, actually, if I mentioned, maybe as high as 30 to 50% of stroke patients may have difficulty swallowing. So you can use it orally, and there's rectal versions available. Clopidogrel is another antiplatelet that's an alternative to aspirin. Some other common medications are, there's several different blood pressure medicine choices. ACE inhibitors like lisinopril, amlodipine is a calcium channel blocker, atorvastatin, and one of several in that class. And there are several others available. All right, so just to summarize here, things I want you to go home with or remember. In acute management of stroke, time is brain. The quicker you can treat, the more likely you're going to achieve a good outcome. If you can administer alteplase, it should be within 4.5 hours of last seen normal. If it's available, mechanical thrombectomy has also shown very, very dramatic, improving dramatically patient outcomes. DTN is door to needle. So if the patient comes to your institution, emergency department, for example, and you're able to give alteplase, the goal is 60 minutes or less. Blood pressure management in acute ischemic stroke, initially we may hold them, and because we don't want to drop the blood pressure too low, and we may restart after the first day or two. If the patient is a candidate for alteplase, then we're a little bit more aggressive about lowering the blood pressure. In acute ischemic stroke, start antiplatelet therapy 24 hours after that if alteplase has been given. In acute ischemic stroke, if patient does require, let's say you do find they have atrial fibrillation or some other reason to be anticoagulated, we typically will wait. We won't start that anticoagulation right away. We'll usually wait anywhere from 1 to maybe 4 up to 4 weeks. And the reason is because if somebody's had a fresh ischemic stroke and you put them on full anticoagulation, you may convert that into what we call hemorrhagic stroke or hemorrhagic transformation. So that's why we usually wait, about I would say on average 1 to 2 weeks is the typical amount of time that we'll wait. For primary intracranial hemorrhage, brain hemorrhage, blood pressure reduction, control is paramount. And then I think what we can all do is try to ensure access, affordability of medications is a problem everywhere. Compliance with medications. Many people will take their medication for a few days and then they're done. I'm feeling better, I don't need to take it. But as we all know, blood pressure medications really it's pretty much continuous treatments, lifetime treatments, statin medications similarly. So anything we can do in terms of education or promoting compliance is helpful. And studies suggest that 90% of all strokes can be explained by these risk factors that can be changed, these modifiable risk factors. And so if you're able to modify these, then you are going to have the best outcomes in reducing further strokes. So again, just to review, hypertension, control the blood pressure, treat hyperlipidemia, diabetes control, have a good diet, minimize alcohol consumption, increase physical activity, and obesity. I think that is all I have. I have a couple of questions. I'm just going to kind of review these questions. If you want to put an answer in the chat, or I'll just go over the answer. So some active learning questions. So which of the following is true about warfarin? So A is a direct thrombin inhibitor. B is a factor 10A inhibitor. C is an ACE inhibitor. And then D, it requires careful monitoring to optimize efficacy, reduce risk of bleeding. Anybody want to say what they think it is?
D, sir.
Yep, D, very good.
Sir, D.
Yep,
Yeah,
great.
that's fine.
And then next question is, which of the following medications would you recommend in a patient with acute ischemic stroke for secondary stroke prevention? So A is enoxaparin, 80 milligrams subcutaneous twice a day. B is aspirin, 81 milligrams orally daily. C is heparin IV, 10,000 unit bolus followed by IV infusion. And D is tenecteplase IV, 100 milligrams.
So B, aspirin, sir.
B, aspirin, 81 milligrams orally daily is the answer here. And then last question here is, you get a phone call that a patient is in the emergency department with an intracranial hemorrhage, so primary brain hemorrhage. The patient has a blood pressure of 200 over 100. Which of the following do you recommend for blood pressure control?
B, labetalol, sir.
B,
Labetalol.
Yep. All right, I am going to stop sharing and open it up. Any questions, please feel free.
Yes.
And
Thank you very much. Really, after the fourth slide, a lot of the information was new to you, but I'm very good that I answered almost all the 3 questions correctly. So I feel good now. So folks, here it's somebody who has done 31 years. Okay, he will answer your questions now. And please be the only question which is a bad question is one which is never asked. Okay, so please ask your questions, and you know we got few minutes, and if nobody asks question, it's sort of I'm sad, but I will let Kiran go after that. So, please, you can.
Sir, I have one question.
Yeah.
So from the audience, anyone has
If anyone patient is diagnosed with intracranial hemorrhage and within 1 month he is suffering from ischemic stroke, so that time we can't give Alteplase, right? So what would be the treatment approach for this patient?
okay, so when you have a stroke, it's either one or the other. You either have an ischemic stroke or you have a brain hemorrhage. You can't have kind of both together. So that's important to remember. And maybe I confuse you a little bit. You can have what's called an ischemic stroke. So it started with that blood clot that blocked up blood supply. And then sometimes in some people, because of that damage to the brain and the blood vessels, they can have some bleeding around in that area. But you can only have either an ischemic stroke or a hemorrhagic stroke. So like I mentioned, for ischemic stroke, Alteplase is the treatment if it's available within that short time window. But for primary intracranial hemorrhage, we don't have any, like in the US even, we don't have any FDA approved medication for that. Now we are testing certain things, like some of the blood factors to try and reverse that bleeding, but there's no FDA approved medication. So it's really supportive care. By that, I mean, controlling the blood pressure, monitoring them, preventing the medical complications. Like I mentioned, the risk of them having like other, like brain edema or swelling, preventing them from getting pneumonia, other clots like, DVT or PE. So those kind of medical, supportive care. Does that answer the question?
Yes, sir. Thank you. And sir, is there any relationship between that you have told that Alteplase should be given within 3 hours, or in treatment approach it can be given within 4.5 hours also? So in case of carotid endarterectomy, there is any kind of that time interval?
Okay, so good question. The original study with Alteplase, when it first got approved, for example, in the US, it had a 3-hour window. Then there was another study done in Europe that looked at it from 3 to 4.5 hours, and that showed that it was also beneficial. So really, for most patients, 4.5 hours is the window, from time they were last normal. Okay, so then the other question you asked about carotid endarterectomy. So for those who don't know, just briefly, a carotid endarterectomy is when in your carotid, we both have carotids that take blood supply to our brain. So if you have that atherosclerosis in your carotid or the plaque, that atherosclerosis, the surgeon can go in, open that blood vessel and clean it out. So usually I would say to do that kind of a procedure, we recommend, we usually try to get it done if a patient requires that within about 2 weeks of their stroke, if possible. Again, that really depends on the surgeon. The surgeon has to decide if it's safe for the patient. But we typically recommend after their initial ischemic stroke that procedure it be done within 2 weeks. Not within the first, I would say probably 24, 48 hours, but anytime after that, within those first 2 weeks.
Okay, sir. Thank you.
Hello, sir. This is Vishal, sir. Sir, one question is that, sir, as in acute ischemic stroke, sir, we have to maintain the BP nearby 180/110. Sir, till how many hours or how many days we have to maintain the BP? And sir, on basis of what parameter we have to reduce the BP, sir?
Okay,
Because,
so
sir,
good question. So Vishal asked that we have to maintain after an acute ischemic stroke, the BP around 180 over 100. We don't necessarily, you don't necessarily have to, let's say the patient's normal blood pressure is 150 over 80. Okay, that's where their normal blood pressure is. We're not going to necessarily increase the blood pressure to get it to that higher number, but we're just going to examine them, follow them clinically, and as long as clinically, neurologically, they're doing fine, you don't need to increase their blood pressure. You just don't want to, if they are high, let's say they are 180 over 100, you don't want to drop it too low, because then you can reduce that perfusion to the brain. You reduce the amount of blood getting to the brain. And then I think the second thing you asked was in terms of how long do we keep it? So normally we kind of let them just stay at their normal blood pressure for at least, I would say, one to 2 days. And then after that, you can kind of bring it down to more, normal range, like the 130 over 80 or less. That's recommended for long-term stroke prevention.
yes, thank you, sir.
Answer the question, yeah.
That some really good questions asked, and I think the recording will be available, so any of you can review it, the material. And Kiran, I will let you go at this point. Again, I very much appreciate it. I think you are really contributing to the knowledge of Indian pharmacists who are just beginning to use their clinical training to improve their hospital. Again, on behalf of all of us, thank you very much for spending a Saturday with us. And I know it's beautiful outside. It was a bad day. I can understand. You didn't lose much, but today it's a very good weather. Again, everybody put in the chat box, thumbs up for what Kiran did for us today. Thank you, folks. And
thank you.
Wait for a few minutes.
Please, anybody, feel free to contact me. You can email me anytime you have any questions. I mean, I try to cover a lot of information in a little bit of time. I mean, I have a lot of other presentations similar to this, but anytime I'm available, even if you need a consult, you can email me. Probably the best way, or even WhatsApp me. You can give my number out. That's available as well.
I will do. Thank you very much, Kiran. And rest of you, please stay. I got a few things to tell you. Goodbye, Kiran.
Okay, bye. Thank you.
Thank you so much, Dr. Kiran. Thank you for giving your time with us.
Thank you very much.
Okay. Folks, let's see here. Option C. Okay, for all the other students, I'm sure many of you from other places, they are not from BMMSH, but that's perfectly fine. As you can see, he did a wonderful presentation. I mean, very clear on what he wants to do, and the recording will be available. Please feel welcome to other friends who could not attend the seminar today. I realize it's 8:30 p.m. and people have other things to do. But for all of you who are here, I just put in the chat box the links to journals.finlay.edu. There are certain things, if you're working in any, say, 10 different hospitals here. If you want to write an article of how many stroke patients they come to your hospital, how many of them are ischemic, how many of them are cerebral, what type of treatments they have, who manages them. I mean, simple things like what has been said here, who does it in your hospital, in your setting, okay? If any of you, there may be 4 different hospitals, maybe in different parts of India, I don't know where the students are from. If you can just compile together an article and send it, I'll be happy to publish in Global Health Online Journal. This is a journal which I run from University of Findlay. I put in 2 issues, 6 articles per every 6 months. Next issue is July, and the one after that will be February. So remember that. And this is Global Health Online. So naturally, for most of the patient, if you don't have any baseline information, you cannot improve anything, right? We need to know what the baseline is. So how many people are coming? So if you write this document up, it will be a great reference for you and for your hospital. So everything is different. What happens in America is not what happens in India. So once you start investigating it, you will find really nice problems which you can answer. And after that, so this is the first step. I will, for the BMS fellow, we will meet again and talk a little bit more detail. So this type of thing, any one of you can do it, right? That could be a good introductory article for us. And if you want to pursue that, I support people to write or submit abstracts for American Pharmacists Association, Federation of International Pharmacists, as well as American Public Health Association. I mean, technically you can write abstract for any of the conferences, but these are the three I go. So I will help you now in whatever way I can to contribute to you so that you're successful in your professional journey. So again, with this, I stop my thing. If you have any questions for me, and if all of you can just type which hospital you are in and which town, either you can open the mic and say that may be better, or even put it on the chat box. In that way, it gets recorded. And have you attended the previous BMMSH presentation? And if you did not, and if you're attending the first one, why and how you chose this one?
Yes, sir. This is Vishal, sir. Currently, I'm doing my internship in the BMMSH, sir, Ranchi, sir. And this is the first time I'm attending, sir.
Hello, sir. Good evening. This is Abhijit Sarkar, sir, from fourth year Pharmacy. Currently, I am doing Pharmacy from Bharati Vidyapeeth University, Pune, and I have already attended the BMS presentations also. So currently, I am fourth year, sir.
Okay, are you doing any? Do you go to a hospital or something at this point?
Yes, sir. Yes, sir. In fourth year, we have to go to hospital to collect the cases.
Okay, so you are, remember the questions I posed to you. You can easily write an article on what's happening just locally in your hospital. So in that particular Pune hospital, or just a general idea on what happens in Pune. How many hospitals are there? Anything.
Yes, sir. Yes,
Based
sir.
on how many hospitals there, how many stroke patients are there, what type of thing there, and why do they get. So, I mean, I'm right now the technology is making us, each one of us, literally start solving problem for anybody around the world. Okay, so if you know patients who are on stroke and nobody's managing their drugs, they don't know about hypertension, they don't know about diabetes. Most people don't realize that diabetes can cause increased stroke, like that smoking can cause increased stroke. So there are many ways. Once we have the data, you can start helping them, and that will become a great career opportunity for you also.
Yes, sir. Sure.
Thank you. Anybody else? You want to tell me which hospital you are from? Where are you from? Let's see, some messages have come here.
Okay, anyone wants to speak, they can just introduce themselves and their hospital, and even you can write on the
just
chat
put it
box.
in the chat box. Oh, I got it here. Okay. Please put in the chat box, where are you from, which hospital? And if any of you want to start writing, thinking of writing this article, you can send me an email, or I will give my WhatsApp message number. So you can send a text to me so we can start working on that. It should be +1 here, I think. That is mine. My name will be Chandrasekhar. Yeah, so you can note it down and you can talk to me or just send me a message. And my goal basically is to help people find a better professional journey. That's all. Because when I was graduating, I only saw 2 English movies in my life before I came to America. Okay. So now I can talk to anybody across the world. And I just want to use the technology and whatever little bit I know in my life on my professional journey to share with you. That's all my goal is. And it's interesting. Ashish wanted some preparatory document for an exam, and I was trying to think what he's exactly asking, and I put it on LinkedIn. Now I have more than 2,700 LinkedIn people, and within 24, I mean literally within few hours, he got the document he wanted. Okay, I felt very proud of myself, and now I have a good network, so I can help direct you. I may not have solution for all the thing, and then maybe things I could not help, but I can. If you are motivated and if you are ready to do your part of the work, I am happy to help you in your journey.
Thank you so much for that, sir. It was much needful. And like I was quite surprised to receive that document so fast.
Yeah, no, I was myself surprised. Okay, first time I realized that there are a lot of people who are good-hearted. They want to help. Most people don't know. Most people have just no idea. But if you ask them, and if you're not asked, if they realize that you're not making use of anybody, I mean, not exploiting it, people are happy to help out the hand. And that's the reason Kiranpal Sangha doesn't have to do it for me. I know him. My wife used to help him with statistics when we were there in his work. And now I know he has done courses in statistics and public health and all that. And he has done for, so each time I go to Cincinnati once in a while, I meet with him because he's got a good heart, and so then he say, okay, I will help you out with it. And think of the resources available to me, Okay, well, it is 12. I will meet Ashish with your group in 4 days. I already sent you the link. If I'm not, I will have sent you the link already. So we'll meet. I think it's in Thursday we are meeting. And for all of you guys, thank you. First, you showed your commitment by attending this session for pretty much the whole time. That's wonderful. And so if any of you want to write up a small stroke article on the city and town and the hospital you're working, I'll be happy to present it. And I tell you, once you get the article presented, it acts as a stepping stone for your next publication or next professional journey. That's all. Okay. No pain, no gain. Okay. Have a good day and goodbye. And I will post the link in about whenever it's available, sometime later in the evening.
Thank you, sir. Thank you so much for giving your time, sir.
Yeah, it's 12 o'clock. I also had a beautiful day, but I'm happy that you made my day by attending the presentation. Thank you, folks. Have a good night. Good day.
Thank
Good
you,
night.
everyone.
Thank you, sir. Thank you, sir.
Thank you.